Well, good morning in India and good evening to all of our faculty and friends that joined us today. We want to thank all of our faculty, panelists, moderators for joining us, and really the IASES, SESI, and IAS, as well as OrthoTV, or Ortho Live, excuse me, TV Live that has done the recording for us. So we want to thank everyone for coming tonight and this morning to join us. I am starting off with the first session today, and we want to give just a real thanks to everyone for joining us and give us some maybe game playing rules. Each session will be about 35 to 40 minutes each. And there's an opportunity to do questions in the Ortho TV. So you can post your questions there. They will be communicated to the faculty, and we'll do our best to try to answer those questions. We're going to really do this as a case-based type of session with discussion. So feel free to ask questions during each session, and hopefully our panelists, we can ask the panelists to sort of weigh in on your thoughts. So we're going to get started now, I think, with the first session. Let me pull up. Oh, sorry, guys. Okay. So our first session is really on kind of the idea of maybe TSA, RSA, what, why, and how, and where we are in 2025. Specifically, the goal of this session for us in our first session we have is to really talk about some case-based and really to challenge ourselves to maybe say what we would do and why we do what we do. We're going to give some votes in, maybe talk about across the seas and oceans here, what we do the same, what we do different, and how we approach things. Specifically, we all kind of use the fundamentals, and that's pretty much an assumption. But I think the bottom line is we all know, and even in it, our Indian colleagues know, that the indications, the type of implants, all of this is really expanding. So that brings us to our first case, okay? So we have our panelists here. So, I'm going to start with a 42-year-old. He's right-hand dominant. He actually works as an engineer for one of our industry partners. And he presents with a painful shoulder that he's had for years. He was a heavy lifter back in the day, and he'd failed a lot of conservative treatment over the years. He had fairly good motion, as you can see, and really good strength, but this is sort of what he presents with, and he's 42 years old.
Hey, Vani, I'm not seeing the case here. I'm just seeing
please share your screen. Please share your screen.
Oh, you're not? Well, it says I'm sharing my screen.
The slides are not moving.
Yeah.
Does anyone know why? Because I was sharing my screen.
Yes.
Can
Now
you
it's
see it
shared.
now?
Yeah, now we can see the screen. Yes, now it's okay. Case one. Done.
Okay, sorry. Well, here we go. So starting over, this is sort of where we are. This is the case that I said. So in terms of the motion and function for this patient, everyone kind of see that. Dr. Arora, tell me a little bit about when you see a young patient, your sort of thoughts in terms of, in India, sort of how do you approach it? What are your first thoughts? What would this patient in your hands do?
So it seems like this is a severely arthritic shoulder in a young male who is a heavy demand patient, probably I'm assuming right-hand dominant. And the cuff quality seems pretty good here. So, I think the logical first steps have already been done. So you've tracked down that pathway of conservative treatment, and you can consider giving them a shot of steroid, but nothing's really going to change the bony pathology here until we jump in and try to fix the bony side of things. So for these sort of patients which are younger, higher demand, so in these cases, we're typically more inclined towards doing a total anatomic rather than looking at a reverse option.
Okay, so here's our kind of CT pre-op planning. Chintan, do you guys use pre-op planning? Do you guys upload it and get CTs in India?
Yes, we have this available. We have the Signature 2 software from Zimmer Biomed, and the Arthrex software for this. Also the blueprint with Striker. So we do have preoperative planning that we use on a regular basis nowadays to plan these patients.
And how often do you use it?
In my case, I use it in every case. It's just a matter of getting a CT scan done and then uploading it. Whether you get a custom guide or not, that's a different story, but planning is pretty much in every case.
And what's the cost of that in India?
It doesn't cost anything additional to upload that, upload the CT scan on the system, and the companies here do it more or less as part of the case. So they don't charge anything extra for that unless you, of course, order like a custom guide or a custom implant.
Yeah, and is the availability fairly good in India for the PSI guides?
It does take some time for it to come. Like for example, if you order it via the blueprint and Striker has to do it for you, then it will take about a few weeks for it to come down. But it's possible.
Yeah. All right, Samir, what are you going to do? We've got this arthritic 42-year-old B2 type glenoid I was trying to show you. What do you want to do for him? And
Yeah,
why?
so how active is he and what does he want to do? What are his goals?
I think he's a smart enough guy to know that maybe he shouldn't be heavy lifting. I think he does fairly just regular exercise. He goes to the gym, he's active, but has really modified his activity from any sort of high impact things over the years.
Got it. Yeah. So I think for me, the first thing, I just saw a patient like this today, and he had been recommended a shoulder arthroscopy for this. And I just kind of looked at it and I said, there's really no benefit in that whatsoever. He's bone on bone. There's really no joint space there. And an arthroscopy on this thing would be absolutely useless, I think. So I think for, my purpose, I'd say that would be just out of the question here. So really for me, this patient comes down to an anatomic stemless on the humeral side, and then on the glenoid side, which is where it gets a little bit more fun, you could do an augmented onlay glenoid, or you could do like a pyrocarbon with a ream and run, or just a drill down or a ream down the little B2 area right there on the ledge there, or you could do an inset glenoid, which is be a little inset. And I think for the younger population, I would lean towards either the pyrocarbon with the just touching up the glenoid, or the inset. And then so for me, between those two, I would talk to the patient about it and sort of push them towards probably the inset glenoid with the stemless arthroplasty.
And do you feel like you still get good pain relief with your inset glenoids compared to, the onlay?
I think compared to the, the pyrocarbon with the, touching up the glenoid or doing a full ream and run, I think I get better there. I think I get just as good right now with the ones I've done on those versus onlay augmented glenoid. I feel like I get just as good. We'll see about the longevity. I think the longevity potential is, based on the research I've seen, potentially better for these younger population versus an onlay augmented glenoid.
Dr. Arora, what do you think?
I have to agree with what Dr. Samir says. He's a pretty intelligent man and knows what he's doing.
Oh, geez. Come on. We need
Come on, Manit. You wanted to scope him, didn't you? Didn't you want to scope him?
No, so I think that we get a lot of these patients as well. And the problem with these patients, as he rightly says, is they get advised an arthroscopic washout. So people who try to look at this in the same way as they still look at knees here, and they think that, just doing a little washout, getting them through 6 months, but it just doesn't work in the shoulder. I know we know this now. And, trying to fight a bony pathology with a B2 glenoid, you've got severe arthritis, you've got a Samuelson forehead. So, nothing's really going to work here. And from an arthroscopy perspective. And I think doing a total anatomic in these cases is the way to go, because it allows you to at least have a relatively pain-free shoulder. And younger guy, higher demand, that's why we'd hesitate to do a reverse. If this guy was older, much older, say 60 plus, has a deficient curve and had that same sort of picture, I wouldn't hesitate to do a reverse there.
Well, what about if he didn't have a deficient cup? I think there's some literature out there, right, talking about the B2 glenoids. Samir brought up a point, in terms of longevity, right, because of these type of implants and sort of the concerns with that.
So if there was 60-year-old and they had an intact cuff and
Yep.
they had this same picture, I would still go for a reverse. So
Yeah.
in my hands, I feel that that works better, both in terms of optimizing their ROMs and also from a perspective of providing them pain relief. So we consistently see their constant scores are good, their UCLA scores are good, the VAS scores. So we try to titrate them for rest, activity, and sleep. And the majority of these patients, they'll come back to us at about 3 months and they're pretty happy. And so they're pretty happy with the sort of outcome that they've achieved already at the 3 month milestone. And from there, they just keep going and going and going.
I think that, I bring this up and you just brought it up in sort of what that age cutoff is, right, Dr. Aurora, in terms of, is it 55? Is it 60 that pushes you? And this is just the chart that I brought up, sort of just to show that shift has really gone away from the totals, right? And Chintan, just question for you, in terms of in stemless in availability in India, whether that would be an option, and then augmented on the poly side. What do you think about that versus an inset?
Yeah, I think currently we still do not have any augmented glenoid base plates for anatomical shoulders yet, and hence
Got
that's a
it.
challenge. So if this kind of a patient came to me with this kind of an arthrosis with mild B2, I would still do a hemiarthroplasty on this patient. Uh,
Okay.
Most likely stemless, yes, or a short stem, depending upon the bone quality. However, the inset glenoids, again, you could use the same glenoid and then ream it a little bit in and inset it. But we don't have those arthro surface kind of implants yet where we can just take care of that small of the arthritic defect on the glenoid and just specifically place that inset glenoid in. So until we have that, that becomes a challenge. So in today's day and age in India, I would probably do a hemiarthroplasty on this case for longevity reasons and avoid glenoid side loosening because of the rocking horse phenomenon.
So Chintan,
Samir,
would
what
you
would you do? A
do anything on the
pyrocarbon or a
glenoid side?
stem? Oh, go
No,
ahead.
we do not have pyrocarbons implants yet in India. The availability is not there, and hence that's what limits us.
Would you do anything on the glenoid side, Chintan? Would you like, touch it up, kind of ream it down,
Yes, I
make it
would.
concentric?
Yeah, I would like to make it a little more concentric as far as possible, and then yeah, use a hemiarthroplasty.
So yeah, and I mean, it's interesting because when you look at the literature, I just put two of these studies up, right? That sort of both systematic reviews over the time, and one says really TSAs don't do as well, and another one says they do just as well. So, I mean, I think in this particular case, this is what I did, and the thought and sort of was, and interestingly enough, is what's the right longevity play in terms of the poly combo. And so, I don't know, Samir, if you had any thoughts on whether you do the pyrochemy over if you were versus the augment, and how much you willing to take in terms of, it was 26 degrees of retroversion, how much you're willing to accept for that inset.
Yeah, talking to Steve Gunther, who really has kind of pioneered the inset, you really can accept a lot, even though the system that they have, you can build in 5 or 10 degrees if you want to. So I on that system, just based on what he's shown me, I wouldn't have a problem leaving it at 20 degrees, especially since he's only 75% sublux. If he was 90% sublux in that situation, I have a little bit more problem potentially leaving him there with instability. But I think with what I've seen in the data, leaving him at 20, 25 degrees with an inset, I feel like I can let him kind of just push on and do what he wants to.
Yeah, and I mean, I think Dr. Aurora sort of brought it up of the fact that fairly most of all these options that we just talked about probably will get you some good pain relief and success. The question is really over time, what does that look like? And
Yeah.
that literature, right, Samira, in Europe is sort of, there is a higher conversion rate with the pyrocarbon, those
Yeah.
hemis, so.
Yeah. Anoop had a
Okay,
question about
any other comments, points, anything else
yeah,
in the
Anoop had a
chat?
question
Looks
about a
like
convertible base plate. Anyone would think about a convertible base plate on the glenoid side?
a good point.
I think there's a lot of bad literature about a metal back base plate, and
Yeah.
hence I don't think that's something that people are using. My question was about using an all poly glenoid versus what Vani has used with those metal pegs back there. Has in the US, is there a complete shift towards metal pegs versus nobody uses a all poly peg anymore? Peg or a keeled implant on the glenoid side?
Samir, you
I'm
wanna-
still using all poly on the glenoid. Obviously, Vani's not. Mandeep, Anand, what do you guys think?
To be clear, I actually use all polys most commonly. This was a particular case where he wanted a little better fixation, wanted that reassurance. So actually, the patient really drove that one. But Anand, Samir?
Yeah, for me, I'm still all poly.
So I'm a cage with metallic pegs,
Yeah.
central cage, backbone graft, and
think there's a lot of
the peripheral pegs.
Yep.
there's a lot of evidence now that some type of hybrid fixation has shown long term, whether it's with Zimmer Biomet's Alliance glenoid or all these. You just have to be careful. I think the key is you also have to have the right poly, highly cross-linked vitamin E. That's what's going to give your longest longevity.
And to Anand, to your point, it's like those are the kind of metal posts or cage, but not what we call like the convertible ones, right?
Yeah,
Yeah.
convertible essentially you're having a base plate that you can convert.
Absolutely. I'm just pointing out that like the idea is I don't think the shift's gone to the metal back. Okay,
We
case
might
two.
cover this later. Hold on.
Yeah, go ahead.
Deepthi had a question about whether we think the reverse and anatomic totals have a similar range of motion and functional outcomes. Vani, you want to
Yeah, well,
start
how
with
about the
maybe-
panel? So how about everyone weigh in? Dr. Arora, what's your thoughts?
So we do many more reverse. I think, the volume bias comes into it because the sort of patients that come to us, they're typically in the older age group. And we don't typically get a lot of these youngsters that are coming in or younger profile patients, relatively young, with severe GH arthritis. So the ones that come to us are typically older. So, I have volume bias for, say 50 reverse, I would do 1 total anatomic. And that's just my volume bias. So if I look at that, I don't think I'd be a very good judge of that. But from that perspective, I found that, either way, you just have to have good patient selection. They do well. Their ROMs are good. Their pain control is good. You just have to be picky with the patients that you're selecting for these surgeries and not try to do, older patient that has a total anatomic, it doesn't work. And then you revise them later in a couple of years to reverse. So I think that, you have to figure out who you want to do it for. And then the results should naturally follow. That's my thought process.
Samir, what are your thoughts? You see probably a fair number of younger patients too, I know.
Yeah, no, I think Manit's right. I think, the patient's got to be like check every box to be an anatomic for me. And if any box is off, then I'll really talk to him about whether reverse is a better option long-term for them. I think to answer the question, I think the range of motion wise, I get similar on both of them, I think really well. And a couple of us, we just did a study. We're still collecting data, but we just took a first pass at our look. And we had with reverses an 87% return to sport at the same or higher level. And with anatomic, the same questions return to sport was 74%, which is statistically significant. So we actually had better return to sport with the reverse. When you look at tennis, pickleball, swimming, weight training, yoga, we had a much better return to sport with reverse than with anatomic. So I think functionally, I think they're actually doing better as well.
In my experiences, I think the older designs of the reverse and the 155 angle might not have gotten us the same rotational range of motion as a total, but I think that's really shifted as the newer implants designs kind of in my own practice in terms of rotation and internal rotation especially has really improved significantly with, I think, the 135 angle. Mandeep, any other questions? All right.
So, again, based on etiology, do you think that the range of motion for RSA versus TSA, for example, Anand brought up a good point that, comparing RSA and TSA for glenohumeral OA with an intact cuff is a different discussion compared to an etiology.
Yeah, no, I agree. And I think
Yeah,
that
actually, what I meant to say, the data I just talked about was for glenohumeral OA. Sorry about that.
And I think the literature talks about comparable range of motion for glenohumeral OA. And the reverse for OA versus the reverse for cuff tear arthropathy is very different. And I think we can see better results, and there's some good literature to talk about for OA specifically. They do better with that reverse compared to your cuff tear arthropathy is a better performing in terms of range of motion and function. So that gets us to the reverse conversation, right? So, I mean, I think this is always kind of an evolving thing. And I think I brought up what I'd call a fairly standard case or simple case, maybe on the younger side, a 54-year-old, but the guy is morbidly obese, right? Type 2 diabetic, has some basic sort of obesity, metabolic syndrome things, chronic pain, and sort of has this physical exam. He did have a previous rotator cuff repair done, or sorry, excuse me, he had a previous arthroscopy done without a repair. And so it's kind of your standard rotator cuff arthropathy case, what I'd call in terms of that imaging. Anyone see anything different, or anything you'd like to sort of note, anything you worry about in these cases?
Now, I think the biggest thing I was looking for is to see how the subscap looked, and it looked okay.
It did. So, maybe in terms of Chintan, how would you approach patient like this, 56 years old, kind of obese? What's your typical workup? He's already had a steroid shot. He's done some therapy, kind of come to you with these symptoms 6 months to a year. What would be your standard kind of conversation now at this point?
This is an interesting patient in which, not only does he have that complete retracted rotator cuff with proximal migration with subluxation, but he also does have a lot of arthritis or wear and tear on his humeral side and his glenoid side. So in my case, the planning is the conversation goes straightforward in a way that, any other option to reconstruct his rotator cuff is not really a long-term solution for this patient. And I would, although him being young, would still counsel him for a reverse total shoulder arthroplasty.
Yeah, so you answered the first question, is there any role for an arthroscopic sort of debridement, repair? What about any other options out there in terms of for you, SCR, tendon transfers? When do you consider those? Obviously, maybe not in this patient with this imaging, but maybe what would be those?
So in a patient who would still have a flexible acromiohumeral distance, in which, if you did a weighted X-ray and the acromiohumeral distance did open up. Also in patients who do not have any arthritis, or those patients are not have a fair range of motion to begin with, in which, if they are not pseudo-paralytic or have a good range of motion with an opening up of the acromiohumeral distance, those are the ones I would do some sort of augmentation, in which I would either, my preference would be a tensor fascial lata SCR, because that's more of a permanent graft in that space, rather than doing any sort of a balloon augmentation versus a biceps transfer. In these patients which have a large supraspinatus defect, I would do a tensor fascial lata SCR. If there's an external rotation lag sign in which the infra is involved as well, those are the patients that I would think of a lower trapezius transfer for.
Chintan, can you talk about when you would do the biceps SCR versus a tensor fascial lata?
I do a biceps SCR or a biceps transfer onto the supraspinatus in pretty much any patient who has a more than 2 centimeter retracted supraspinatus tear, because I think it just adds on to the
Cuff repair.
the cuff repair and helps stabilize it. But I would do it only in patients who have an anterior supraspinatus defect. In patients who have a very large posterior retracted supraspinatus, I think tensor fascial lata SCR would be a better option, because the biceps doesn't cover that entire defect then.
Right.
And how much does the bone loss or that bone deformity play into your decision?
The glenoid bone loss, you mean?
Yeah, or the glenoid bone loss, the high riding humeral, the hamada sort of changes that you see.
Yeah, exactly.
Either on the glenoid or the humeral side.
Yeah, so if the hamada grade changes in doing a weighted X-ray, and those patients are the ones that I would consider doing any of these grafts in between and not do a reverse shoulder arthroplasty. If this patient has a fixed proximal migration, then it doesn't make sense to put in a graft. It's just eventually going to fail in any case. So I would then think of a reverse total shoulder arthroplasty and then, discuss longevity with a 54-year-old patient like yours.
And Manit, so what do you think about, and kind of what is your guys' availability in terms of when you approach the reverse? A bigger obese male, do you lateralize more? Do you use an inset or an inlay humeral side? Tell me your approach kind of in terms of these massively big or obese guys, which you don't really see in India, but
if I could just go a little bit back in the discussion,
yeah.
If this patient has slightly less arthritis, so they've got a posterior superior cuff tear, obviously a repair is not going to work, right? So as
Right.
Dr. Chintan was saying, maybe a repair plus would be an effective tool with a lesser grade of osteoarthritis. But, you can always consider doing a balloon. The subscap's intact. So, for me, if this patient had a earlier sort of picture and they came to me, say at, in an earlier arthritic component, I would talk to them and say that, look, you're quite young for a reverse shoulder, and I'd like to buy you maybe, 4 or 5 years of your life. And I would suggest to them that you've got an intact subscap, you've got a posterior superior cuff tear, which is irreparable. So why don't we just give you a bridge therapy in the form of a balloon? So let's get you through the next three to 4 years, because remember, they're not pseudoparalytic. So they have a good ROM. And for them, the main problem, it seems, is pain. So we know, luckily for us, when we got these balloons, we got it after the West had used it and abused it. And we got it at a time where we really understood what the indications and the contraindications were. So, and we know it's a vertical plane stabilizer, not a horizontal plane stabilizer. So inserting this, depressing that humeral head, allowing the deltoid to, cope and sort of strengthen up over a period of time is only going to make my reverse better. The outcomes are going to improve once I go back in and do it. And I just like everyone's thought on that as well.
And what's the availability of the balloons? I mean, are they
So I do the highest volume of balloons. So Bice.
okay?
But yeah, so I'm using it as a bridge therapy to get people to a reverse, or for those people that are too old where I feel it's too risky for them to undergo or not beneficial enough for them, and it's a shorter procedure. It allows them their pain relief, but we have our strict indications and contraindications. So thanks to you guys. So we know that, don't do it in the arthritics, don't do it in the pseudoparalytics. Don't do it in people that have bad subscap tears. If you've got a partial subscap tear, that can be repaired when you're doing the balloon. So it's a balloon plus procedure. But in terms of providing them with pain relief, and remember, the role of the balloon is just to help depress the humeral head. So allow the deltoid to retension, allow your force couple to work properly. And then when I go in and do my reverse, I'm going to be a much happier surgeon, I feel, when I'm going in later.
So Samir, we gave up on the balloon, wasn't available, can't get it in the US, so he gets a reverse. Can you tell me, if you preoperative implanting, this is sort of your case, what are your goals? Like, what do you try to achieve in that? You know what I mean? Where do you correct it? How much inclination are you willing to accept, version? What's your kind of goals in terms of lateralization? Do you use an inlay, inset, onlay? Tell me how you
Yep.
approach it, maybe.
Absolutely, yeah. So I think from a preoperative planning, I think there's a lot of things to look at. I think I look at overall medialization of the humeral side. So if I look at sort of the lateral edge of the humerus versus the lateral edge of the acromion, if they're medialized to that, I know I need to get their whole construct out lateral, beyond that. So I'm looking at that first and foremost to see how much room I have to do an augment. And so in this case here, I think there was enough superior wear that an augment superior posterior is going to really help. My goal on the tilt is to get between 0 and -2, or 2 of inferior tilt. I don't really need more than that, because I think when on the blueprint system that I use, it a little bit over exaggerates the superior tilt. So even if I'm 1 or 2 degrees superiorly tilted, I feel like I'm going to be fine just based on the exaggeration of what I get on that. But I'm usually shooting for 0 to -2 on that. In terms of tilt. For distalization, I'm looking to try to get between 2 to 2.5 centimeters on average, maybe a little bit more in a bigger person, a little bit less in a smaller person. And then lateralization based on sort of how medialized they were, I'm trying to get between 5 to 10 millimeters of lateralization, kind of looking at that and just kind of looking at all these pieces together to see how they fit. And then I put it through that sort of range of motion parameter that Blueprint has to see kind of how things look and how the arc of motion is. I want to make sure I have at least 35, if not 40 degrees of extension, if not more, to make sure I get that internal rotation going there as well.
So I think the question sort of how much in terms of when you do an augmented, first of all, maybe I'll ask the whole panel, what percentage of base plates are you ending up putting in with an augmentation? Maybe I ask everyone that first.
15 plus degrees of retroversion.
And what percentage do you see of the cases that you see in India end up with an augmented base plate?
I would say a good amount of 50% possibly.
Okay. What about you, Manit?
Yeah, I'd say about 30-40% of my practice is now augmented base plates.
Augmented.
Yeah.
Samir, what about you?
Yeah, I'm about 45-50%.
It's really, isn't it crazy how far we've come from just a few years ago in terms of even availability? What's the amount of lateralization for each of you guys that you try to shoot for? Maybe, it's a caveat, I know. Maybe give me whether you do humeral or glenoid lateralization typically, and then maybe what you shoot for that global.
I start off with planning, and in my planning, I'm noticing that the more amount of planning I'm using, the more amount of lateralization I end up putting in. Depends on the system I'm using. If I'm using a biomed and if I'm doing an augment, that's already a slightly lateralized system. Our patients are relatively smaller. So if we put in a lot of lateralization on the glenoid side, then we obviously tend not to put as much lateralization on the humeral side. And we need to balance that out in a way that we don't overstuff the joint.
Manit?
I use Zimmer Biomed, so I'm completely, the opposite of
Humeral
that.
lateralized.
Yeah. So I always lateralize on my humerus. And
how much do you do on the glenoid side? Because they have that available. Do you tend to do
so,
a lot?
Yeah, so in 30-40% of cases, I'm anyways, putting in my augmented base plates now. So I am lateralizing there as well. And I think the key as well is for people that are starting out, you don't want to overream. So you don't want to end up sinking in your, base plate and end up with you're starting on the back foot and you're building up from there. So, and at the same time, you can't over lateralize. We don't want people coming back with sort of right angled shoulders coming to us and saying that, this prosthesis is jutting out of my body.
And then Samir, take us at the end.
Yeah, I think the biggest thing, people need to look at is what they have on the humerus that they're using. And, if you're using an onlay implant on the humerus, you have to be much more careful about what you do on the glenoid side in terms of lateralization, because you can really overstuff because you have that onlay, and so for me, I've switched towards a sort of a flush lay thing that I can make onlay if I need to, so which gives me a lot more freedom to lateralize on the base plate or the glenosphere, or both if I need to get them out, and then just be able to kind of match it on the humeral side based on what I need to kind of balance the shoulder out and not overstuff them. So that's kind of for me. But, from an overall lateralization, I want them to be about, 5 to 8 millimeters lateral to the acromion, and then distalization, as I mentioned, about 20 to 25 millimeters.
Yeah, and I've really sort of changed and shifted, shout out to Anand and the hands team, but I was going to show a case, but I've gone smaller and gone more lateral. So I don't know, but I've seen that shift in my own hands, and I've actually seen better functional range of motion with that. We used to try to put the biggest glenosphere on, right, to try to give us stability. And I really think it's been a mind shift of really not distalizing as much as really lateralizing. And I've seen that really, for me, functionally has benefited the patients.
Yeah, I'm always either lateralizing on the base plate, which will give me, if it's a wedge base plate, it'll lateralize. And if I'm not doing that, I'm lateralizing on the glenosphere pretty much between those two 90% of the time, if not more.
Yeah. All right, so we're going to end because Chintan was able to submit a case. So Chintan, you want to take it away? Maybe just tell me when you want me to change the slides.
Yes.
Vani, can just though I'm not part of this panel, I'm just itching to ask
Absolutely.
questions. Just one thing is, you told that the outcome and the range of movement with the total shoulder for osteoarthritis is better than doing reverse is better as compared to a total shoulder in the diagnosis of osteoarthritis?
I would maybe take a caveat, Karthik. I think total shoulder versus reverse for the same population, the literature in the past has really said that the total shoulder has had better range of motion. I think there's some newer literature to say that that might not be the case and there might not be as much of a difference. But I think the difference we were saying is reverse for cuff tear arthropathy versus OA.
No, when you do a reverse for a osteoarthritis.
Yeah.
I think the panel sort of agreed that a reverse nowadays gives a better outcome in osteoarthritis compared to total shoulder. Is that the message, or it's still total shoulder for osteoarthritis, primary osteoarthritis?
So, I mean, I'll let the panel weigh in and then I'll say my.
So that is one thing. The next thing is when you do a reverse shoulder in a primary osteoarthritis, the shoulder is a stiff shoulder compared to rotator cuff arthropathy. There is a lot of stiffness, and you will have to do almost sometimes when you put these lateral glenoids, which are probably the only ones available in this part of the, then you end up actually tightening the shoulder too much and having to release a lot of cuff. So once you release so much cuff, then what sort of function are you expecting out of that? I mean, you have a little bit of a subscap here in the front and probably have released the subscap, the supra and infra already, which if you had put a total or if you had put so what are the tips and tricks when you put in a reverse in an osteoarthritic patient? Would you actually lateralize or would you not at all? Would you, I'm talking about a osteoarthritic patient with probably little glenoid wear and not much of deficiency on the glenoid side.
Well, so maybe I'll give my 2 cents on the second question. And Samir, do you want to weigh in on the first? Or you want to flip it?
Yeah, either one. I'll do both too. Yeah.
So, I mean, I think that stiffness, I'll do more releases. And I am thoughtful about how much glenoid lateralization if I use an augmented base plate, specifically to make up for that bone loss, if it's like a B2 glenoid. But I still find that I don't typically release the cuff. So if there's remaining cuff there, I'm never taking down infra, you know, and I'm fairly able to do subscap even repairs. But that being said, I went from an onlay type prosthesis to more of a, as Samir has says, a flush lay or inlay prosthesis. And I have found that that's been more able to achieve that in a tight OA patient and still lateralize on the glenoid. Samir, your thoughts?
I think that's exactly right. You know, if you're trying to do, and that's what I was saying before, if you're trying to do an onlay with an arthritic patient with the glenoid that has got some retroversion, you need to lateralize them, then you're really going to be stuck over tightening them and having to release the cuff. And I think that's a failure that you don't want to end up doing. I think that person, you really need to think about an anatomic then for that reason. But for me, it's exactly the same thing where, you know, I'm looking at the overall, how medialized they are in terms of, and then where I need to do on the glenoid, but because I have the implant that it's more a flush lay, I end up not, you know, overstuffing them. And I think the key with that is making sure, you know, you do not do that, because if you are, you're really hosing them, you're making them worse because you're releasing the cuff that they had before, you know. And I think with current day implants, with proper planning, you can get that on a very consistent basis. And then secondly, the first question, you know, what I was saying was that from a functional standpoint, Karthik, we just looked at about 1,000 patients after reverse and anatomic, and we found for all comers, but return to sports, when we looked at the cohort of reverse for OA, the return to sports was higher in the reverse population than in the anatomic population by about 86% versus 75%. So that was something that we thought was surprisingly, but good news, you know, so that the reverse patients actually do really well in terms of return to sport.
And I would say that functionally, in terms of range of motion, there is, you know, some literature to say sort of that the range of motion for a total might be more anatomic than a reverse. That was the traditional way of thinking, Karthik, in the literature. And I just think that that's slowly been shifting to see more comparable range of motion. So I think that's the big shift. I don't think I would say that the range of motion is better with a reverse. I think as sort of Samir puts out, the longevity, the return to play, more the durability might be better. But I still think in a young patient, functional with an intact cuff, I mean, in my hands, a total shoulder is a very successful, viable solution that I would choose handover for a less than 55-year-old patient.
Yeah, I agree. I think the patient I'm talking about is like the 73, 74-year-old that has a good cuff right now. I think for that patient, I'm still going to lean towards the reverse because I don't want their cuff to fail in 4 years like every 78-year-olds does. That person, if I put a reverse in and make it, a little bit, looser, balance them out like an anatomic, make sure the subscap repairs nicely, then I feel like they have the best of both worlds.
And I think it's very important as well that, whatever function that they had with this deltoid and these soft tissues prior to coming to you. So the way I look at it, it's my duty to preserve that as much as I can. So I'm very robust on my subscap repairs, and I try to, at least get them back to as close as possible the way that they came to me with or better.
Yeah.
I think
it's a
it
real
makes
shift.
sense. I think if you don't mind, I think it makes sense to keep your reverses a little bit looser in patients who are osteoarthritic. And a neat way of doing that I learned from John Sperling and also with discussions with Dr. Samir is that in Zimmer Biomet on-lay reverses also you can leave them loose in a way that you can dial your glenoid on the opposite side so that your inferior angulation is a little lesser. And then that makes them a little more looser. Your rotator cuff does get repaired quite well. So I've done a
It's a
few cases
slightly
with that.
posteriorly pointing glenosphere.
A superiorly pointing glenosphere.
Okay, well, Chintan, I'm sorry we ran out of time. Like always, I prepared 5 cases. We did 2, so we're gonna keep moving to stay on time. And I really appreciate Anand, Mandeep, everyone sort of responding in the chats. Really, thank you for managing that for us. If there's any other interesting questions, please keep bringing them up. So I'm gonna leave it to our next moderator.
Thank you very much, Vani. That was an excellent session, and thanks for the initiative.
Thanks, everyone.
Samir, thank you. It's good to see that elbow took some precedence in the shoulder group. That's very nice because I'm an elbow guy too. So I was really pleased when Mandeep suggested elbows. So we'll talk a bit more about elbow arthritis and more onto the cases of elbow replacements. Unfortunately, in India, to give you a background, we don't have many options for elbow replacements. We only have the Conrad Murray, but no other design is available. So we don't have that much choice like you would have in US. So I think we have all our panelists. I think Karthik.
Yeah.
Karthik,
I'm here too.
Hi, Ram. Welcome.
Hi, I'm here. Good morning. Thank you.
Hi, Ram.
Hello.
Hi.
Okay. I can't see Karthik live.
Karthik is there.
Sir, I'm here. I'm here, sir. I'm here. Yeah.
Yeah. Okay. So let's start with elbow arthritis discussions. I think first case, the theme today has been young arthritics. So we'll go with youngsters again. But this in elbow is too young. Okay. I'm getting a few of these patients, and it's a very tricky situation because this guy is 23. He's an IT professional. He's on methotrexate, all the biologics. He's going on with the treatment. All his rheumatoid arthritis is well controlled, except for his elbows for some reason. And for the left elbow is totally ankylosed at 70 degrees, and he's able to manage his day-to-day activities. The right elbow, he has pain and stiffness, and that's the range of motion he has. And now he's coming to a stage where he's having difficulty in eating. That is the biggest complaint he has. So what are your thoughts, Mandeep? Can we just start from here?
Sure. So when I do evaluate these patients, one of my questions is, how's your elbow pain? Is it present at the extreme of range of motion, or is the pain present throughout the arc of motion? I think that's a very fundamental question to start with. Basically, planning for an elbow preservation kind of a surgery, where you could call it debridement, open arthroscopic or whatever, or an elbow replacement surgery. And the other thing is like what kind of underlying arthritis it is. People with inflammatory arthritis, they are going to have a really erosive kind of an arthritis, which is going to have pain during the arc of motion and can also develop pain at the extremes of ranges. And, based on the patient's response to that question, then I will determine the kind of procedure in addition to other things, and also give them a prognosis on what's going to get better and what is less likely to change. And then, I'll slowly get into other discussions, but I'll wait for your next question.
So this gentleman has pain throughout range of motion, and night pain is there on the right elbow. And there is swelling in the elbow, very obvious, and it's warm to touch. The elbow is warm to touch. The right one is almost cold. So the left one is cold. The rest of the joints, no morning stiffness. He has good function in the other joints. Karthik,
sorry, go ahead.
Sorry, Karthik, what did you want to do?
Sorry. I would like to get, next step will be to get an X-ray and get his TSR, CRP and counts to just see what's his status with inflammation and see an X-ray.
Okay, so that's the blood point of view. His CRP is around 15. His ESR is 30. The CBP is, he has a HB of around 11.
Okay. So rest of his joints are all, the rest of his joints, he has no much pain. This is the only,
yes.
So it's more like the mono article, this elbow is right now giving him the trouble.
Correct.
And so the MRI is already there. On the X-ray, we can see that there is some amount of arthritis. The coronoid fossa, you can see some sort of an osteophyte or a filling up of the coronoid fossa. And on the AP X-ray, you can see that there is something in the olecranon fossa as well, probably loose body. And on the MRI, we can see from the sagittal cuts that there is florid synovitis along with some loose bodies. And there is this coronoid area also is full, and definitely this is going to restrict its flexion and also extension. There is good synovitis, good amount of synovitis in the olecranon fossa, filling that fossa as well. So, so I'll discuss with the patient what he wants, and if he wants good range and he wants then we'll have to suggest him surgical option. The non-surgical option would be actually a intra-articular steroid shot, which will take away the pain for some time. The warmth and the pain and the inflammation might go down, but he might not get a lot of movement. So
he's already on medication. His elbow inflammation is not controlled well, and there is the intra-articular steroid option was given to him, but that's not going to improve the range of motion, is what I felt. Mandeep, what did you think? Would you go for debridement, or would you think of an elbow replacement at this stage? You're muted.
Are biologics available? Are biologics available, Dr. Adla, in India?
Yes, they are available. But I'm a bit wary about how they're used and who uses them, because sometimes the orthopedic surgeons are starting them, and that's a worrying thing. I always ask my rheumatologist to see them, and some rheumatologists are doing it, but I'm not clear about how well they are versed with their biologics and their.
How good is the biologics in rheumatoid elbow?
So here's the thing. Obviously, Ram, I'm not an expert on it. I totally rely on my rheumatology colleagues. And this case in particular, where a patient has some sort of an inflammatory arthritis, all of the joints are quiet, but elbow in particular, one or bilateral, they are not just responding to anything, including biologics. And that's when typically the rheumatologist will contact us, because these patients, they had arthritis. Those radiographic changes did not develop overnight, but it's the synovitis, it's the impingement at the extreme, which is giving them pain. Dr. Adla mentioned that the patient is having pain throughout the arc of motion. So I'm going to blame synovitis. I'm going to blame, effusion as the immediate cause. Answering your question, Dr. Adla, I would actually, if I'm seeing this patient for the first time, I'm definitely giving him a steroid injection. I'm definitely watching his response. If he responds in 6 weeks, because the response to steroids is pretty acute and they'll feel really good. If not, then I'll talk to him about a debridement / synovectomy that you have outlined. Whether you do arthroscopic or open is totally, up to the user and whatever you feel comfortable with.
I
And
think
my personal preference would be arthroscopic.
yes,
So
I think I agree. Basically, Nandan, the left elbow is ankylosed. So he has got rheumatoid arthritis. He's on treatment. The right elbow at the moment, he has a florid synovitis with early arthritis. There is not much of a subchondral cyst or lytic erosions in the elbow, not like advanced rheumatoid arthritis. So it's, in my opinion, ideal case for arthroscopic debridement, complete thorough synovectomy, intra-articular procedure, release the posterior impingement, anterior impingement, and that would run for some years. Then eventually the elbow can tend to get worse in the future. At that time, we will consider elbow replacement.
So I think in just to put that together, I think if the medical management is not clearing the synovitis, you clear out the synovitis surgically, and you also release the bone. If you can improve the range of motion, it's well and good. So that is why we went for the arthroscopic synovectomy. And that's what he had, a synovectomy, and also all the osteophytes he had mentioned, they were not loose bodies, Karthik, they were all osteophytes. So we excised all the osteophytes, and that's after the release. I did an mini open ulnar nerve decompression in association with this, and also did excision of the osteophytes. In spite of excising all the osteophytes, he did not get the full range of motion. So one key thing I learned here is that when it's a juvenile rheumatoid arthritis, this chap has been having rheumatoid from the age of from 6th class. The growing end of the bone does not remodel as normally as a normal elbow does. So the shape is not as normal. So that's one of the things I learned from this. And so don't aim for a full range of motion if you can. Just clear the synovitis and improve it. This is post excision of all the osteophytes. I took out everything possible. But still, if you see the shape of the distal humerus, it's not the ideal, it's like a normal distal humerus. So maybe that is the reason he didn't get the full range of motion. And I'm sure I did a full 360-degree release, but still I couldn't get it. So that's one point I learned from this patient.
Deepthi sir, I had
yeah. Tell me.
Hello.
Yeah, hi.
Am I audible?
Hear you. We can hear you.
Hi.
Welcome.
Yeah, this is Krunal here.
Yeah,
So I had a question. When we have this inflammatory subset of patients and the other subset of patients which we get of elbow arthritis are post-traumatic, rarely primary osteoarthritis. Investigation-wise, is there something different that you would do in rheumatoid patients in comparison to the post-traumatic ones?
Investigation-wise, I think I would go by the anti-CCP and I would go by the symptoms most of the time rather than just a test, because the symptoms of early morning stiffness and those things give you a better idea about the disease activity than the investigation itself. So Mandeep, what are your thoughts on that?
Yeah, so, first, you brought up very important. So when I talk to my patients who come in with elbow arthritis and pain, most of these patients are sometimes surprised saying, I have elbow arthritis. The reason being they do not notice mild limitation in stiffness initially, and it is pain that brings them over. So when I indicate them for surgery, I tell them like, hey, I'm going to be, for example, if I'm doing an arthroscopic or an open debridement, I'm basically taking the capsule, the loose bodies, the olecranon process, the coronoid. So I'm basically taking away end range mechanical impingement, which will give them pain when they're doing a throwing arm motion, when they're doing kind of like lifting weights. But I don't promise them full range of motion. If they come to me with, let's say, 40 degrees loss of extension, I'll say there'll be a 50% improvement, give or take, which means from 40, I can bring you to 20. And if they are at 100, I'll say I'll take you to 120 if 140 is your normal. Even though in the OR, you are able to get 90, 95% plus range of motion, unless you have a really contracted elbow. So that's one thing I try to make sure that patient understands really well. Terminal range of motion versus arc of motion, and giving them a prognosis that I will take care of the pain during terminal arc. The pain during the rest of the arc of motion may not get that much better. And same thing with improvement in range of motion. as far as preoperative testing is concerned, fortunately, majority of that is already done by the rheumatologist, unless patient has kind of like a post-traumatic arthritis, where I am the first point contact person for that patient. So for me, imaging wise, mainly what I do is the CT scan after radiographs when I'm indicating them for surgery, but I typically don't do much of blood test or anything else in order to figure out what's going on.
I think the
Are you going
most
to
important.
look? Are you going to look out for ulnar nerve issues
Yes,
actively? Yeah.
definitely. I think checking ulnar nerves preoperatively is very, very important. And when you're doing arthroscopic release, don't do them blindly on the medial side, because that's a very good, very important part. And always check for your subluxing ulnar nerve before you plan for any elbow surgery.
Okay.
The most important thing in inflammatory arthritis is clearing the synovitis, because if clearing synovitis prevents articular damage.
And when you want to release a certain degree of stiffness, as a higher degree of stiffness is there, the arc of movement is less. I think it is very important to do a prophylactic ulnar nerve release on the medial side.
And if you can't do arthroscopic and open capsular, osteocapsular plasty is very well recognized for mainly for osteoarthritis. I used to work in Sheffield, so we used to get a lot of osteoarthritis. We used to do a lot of these OK procedures. So I did review, I did publish on this, and we found that the outcomes are similar. If you are good with your arthroscopy, you should go ahead and do an arthroscopic. But if open is also a valid way of clearing up the elbow joint. So we'll go to the next case, more straightforward. 67-year-old lady, rheumatoid on DMARDs, low-dose steroid, long-term, pain and restricted movement, and range of motion currently is 40 to 80, and it's affecting her ADLs, and no distal neurovascular deficit, no hand deformity, no shoulder problem. So that's her X-ray. So all of you agree, ideal case for total elbow?
Elbow replacement.
Yeah.
Yeah.
So that's the X-ray again, just so that you are reminded of what you can see on that. So preferred surgical approach. Mandeep, what do you do for your total elbows nowadays?
So mine is a posterior approach, in which I usually, for addressing the tricep, I do the tongue approach. Tricep on only if it's a traumatic condition where there's a lot of space available after taking out the fractured fragments, but typically, the tongue approach for handling the triceps.
Okay. Krunal, what do you do? Krunal, are you there? No. Ram?
I used to do a lot of Campbell tongue approach in the past, but changed to triceps preserving approach, para tricipital, para olecranon approach, and dislocate the elbow and do that, because of the concern with the triceps mechanism, especially in rheumatoid.
And
that's
in
my
patient, any concern when you do that?
This patient, I think olecranon is very thinned out.
Thinned out, yes.
Thinned out. Yeah. I think that one is the preparation of the olecranon, which is the key for any elbow replacement. True. And we have only one prosthetic system in India too, with restriction. So that you have to be extremely careful in preparing the proximal fibula. When you do this triceps preserving approach, sometimes you have a difficulty to access the proximal ulna in good way. So a tongue approach does help if the proximal ulna is very thinned out.
Karthik,
what
approach is your preferred approach?
Yeah, so I'm the other way around. I used to do the triceps on, and especially I pushed it to a limit now, did it on ankleized elbows and this and that, struggled. And then started doing the triceps tongue, and I find it extremely good. And surprisingly, the patients regain movement very quickly, and the strength recovery is also pretty quick. That's why I always used to fear about cutting the triceps and all that. But after doing this approach, sir, that I feel that it is I can allow the patient to do range very quickly, and the patient is also able to regain the extensor strength also. I don't find a big extensor lag in these patients. Okay. What is your...
I used to do triceps on with a split. Mostly I trained with David used to do only a triceps split. But again, and now I moved on to tongue, because most of these are contracted. And when they're contracted, you have a chance of doing a VY-plasty later on with your triceps. So you get a good triceps tension too. So
Dr. Adla,
yeah,
there's a question from the rest of the faculty just wanting to know on the panel, how many total elbows per year are we doing?
It's not a big number.
Around
Not at all a big number. In fact, when I trained in elbow surgery in Sheffield, I did more revision elbows, total elbows than primaries. In the 6 months, I did about 15 revisions and I did only 2 totals. And after that, yearly, I probably do about 4 or 5. That's it.
I think in the UK, we used to do around 20 to 25 per year. But in India, it's a mixed indication, rheumatoid, post-traumatic osteo. So I would say around 10 a year.
5 to 10, yeah. 5 to 10.
So I'm probably the lowest number volume guy in the panel. So for me, in last 5 years, it has gone down to anywhere between 2 to 4, and 50% of these are revisions, which is largely for PJI or prosthetic joint infection.
Joint infections, yeah.
Because the biologics, not the methotrexate or the DMARD, biologics have totally, you don't get to see rheumatoid patients with a hand deformity.
Yeah,
Yes.
that's what happened to my hand surgery practice too. So I've just stopped doing most of the elbow hand replacements too.
But what is the compliance in US? Are the patients very compliant with medication? Don't they go for alternative therapy, this and that, and come back with do you see them?
Yeah, I think a lot of patients, because they don't have much deformity or pain, only the ones that I get to see are not typically young patients. They are like in their 60s or 70s, the ones who didn't get biologics on time. And they go to 4 or 5 consultations where majority of people are actually not doing total elbows. And they're passed on from one surgeon to another. And when they get to me and I tell them like, hey, there's a 2 to 4 pound weight limit on this elbow, and they just slowly track back.
Yeah.
Actually, traumatic indications are on the rise.
Yeah.
And those are the indications in which actually there's a higher failure rate.
Yes.
40 or a 50-year-old with a non-reconstructible distal humerus fracture, I love my trauma. But they are the ones who end up doing those. And, invariably the stem is on one side and the entire cement mantle is on the other side. So
this patient, I did a tricep split approach, and then I did the intraosseous repair back onto the triceps, and that's the post-op X-ray. And that's a post-op X-ray. And then when I was doing my surgery, I asked my assistant to hold the arm for the cement to be hardened. And you see that curve in the olecranon. I was asking him to be very gentle on it, but he wanted some more range of motion. So he pushed it, he hyperextended it a bit more. And this is post-operatively. If you see carefully, he had an olecranon fracture exactly at that point of that thinning of the olecranon. This is a risk. And because I did an intraosseous suture, there's something, everything is holding together. So that was the saving grace for her. So I just left her into heel and mobilized her. That's her post-op healing. That's the X-ray about 6 weeks post-op. And this is her about 10 years down the line now, almost coming to 10 years now. And that's the range of motion she has. So even if you get a fibrous union of the olecranon with a good triceps function, they will do well. And she's not loosened at all a bit, even in the 10 years. So rheumatoid with a total elbow replacement is a good option in the long term.
Dr. Adla, there's a room for a question. So Dr. Murthy is asking, what's the experience of interposition arthroplasty in India? And then I can share some thoughts on my side of the US as well.
Okay.
Especially in younger patients.
Yes. So interposition arthroplasty, I should say, for me, it's historical because when I was in UK with David, we did a few of those cases and the experience has been bad. So I have not done them and I have been taught that they don't do well. That's the reason I've been away from it. We have done interposition with graft jackets, we have done with tensor fascial lata, we have done external fixators, and the outcomes overall have been bad. So I did not go it. Ram, I don't know if you have done any.
No, I don't have personally not much experience with interposition. In the young patient, I tend to do arthroscopic or open capsular release and get going. Young traumatic arthritis, but I do accept there is a good indication. And there are good published reports with excellent results as well, but no personal experience.
Anand, would you mind sharing your experience about ulnohumeral interposition? Seems like you're doing a lot of those.
I mean, not a lot, but if you have a 40, 50-year-old laborer, I don't think a total elbow is a great option when they have severe ulnohumeral, either OA or rheumatoid. So been doing interposition with usually double or triple Achilles tendon. Typically, you have to either shotgun open from the lateral side, and then I'll use an internal brace for their ligamentous. But I don't put a frame on or anything. I usually just brace them for 6 weeks. They're done okay. They're okay. I'd rather do that than a total elbow.
Karthik, any experience?
No, sir. No, I've actually tried doing the interposition in an ankylosed elbow in a young patient whom I actually took down the ankylosis and then made a sort of a fishtail in the elbow and then tried putting a little bit of fascia there. That's my only experience. He's done reasonably well, but for a primary osteoarthritis, I'm actually interested about Dr. Anand's technique as to what's the range you can expect, how much pain relief, how long will it last, what is the sort of advice you can give the patient.
They have to have a balanced elbow, can't have severe deformity, I usually use transosseous sutures with double or triple overlay folded over Achilles tendon, and I make sure to repair their ligaments as well. I do it all from the lateral side, take down the extensors, or I'll do an epicondylar osteotomy, kind of like an LTO, and open the elbow up that way, and then repair that with a plate or anchors. Hinged brace for 6 weeks, absolutely no motion, and then start their therapy. Takes about.
So do you dislocate the elbow? You freshen the bone,
Get the
or
entire elbow freshen. I kind of drill little holes. I don't like to take much bone away to keep it balanced. So I do bring in 2 or 3 a year. It's not a lot, but
okay.
So quick case on ankylosed elbow. Same again, JRA. This was an ankylosed elbow for 5 years. On the right side, she's been having good functional range. For this lady, she wanted some function on the left side because she didn't want to go ahead for the elbow replacement or even a clearing of the joint, because I did an MRI, and MRI on the right elbow, which has a good range of motion, did not show any acute synovitis. One. Second, there was damage to the articular surface. So I was not keen on offering her synovectomy as such. And was able to do her activities, so I left her alone. She wanted something done for the left elbow, which is ankylosed for the last 5 years. So as Karthik mentioned, these are very challenging. So in these, I went ahead and did a tongue approach, like Mandeep said, and that's the ankylosis. Okay. So we did a re-osteotomy on this before we go ahead and did a elbow replacement. Okay. Once that is done, you take it down, and that's the movement in the elbow. You dislocate the elbow, and she had a total elbow replacement. That's her final picture. And that's the delight you get. She never could touch her face for 5 years. That's the first time she's touching her face in 5 years. And she's still maintaining the motion. This is now 2 years. That's her range of motion now. Extension, I'm a bit disappointed. I got it full on table, but I'm a bit disappointed. I think the triceps may be the reason. I don't know. Any thoughts?
Patient doesn't mind that, sir.
I think happy to have flexion that much from ankylosed to elbow. Great job. But I think they are very challenging indication, and they tend to have a little bit of early heterotopic ossification. That is maybe the cause for extension stiffness also. Okay. But good results, excellent results.
So Dr. Adla, question for you.
Yeah.
We have a few minutes. So total elbow in young patients, do you have any concern for future loosening? Like, how do you counsel them? Is there a weight limit that you tell them? and any kind of particular activity that you tell them, like, hey, try not to do XYZ versus you're allowed ABC?
Yes, I do tell them that you should take care of them carefully, because I did tell them not to lift weights more than 5 kilos.
5
And
kilos.
I do tell them that there is a chance of loosening, especially in the youngsters. It's very important to give that message out before we even start this, because these come loose. And I have done twice revisions, 3 times revisions back then. But so I'm confident that when they come loose, we will be able to salvage that. And it is not very, very difficult to salvage that. And in fact, I have a case. If you have time, I can show you that. But if we are running out of time, I can't do it. What time does my session finish?
I think we have like two minutes max.
2 minutes.
If you want to quickly go over and show just a.
Please,
I can
please
run
show
through that revision sort of scenario.
That'll be more.
Because at 10:45, we want to hand over to Dr. Murthy.
Yeah. So sorry, this is the other one.
So I will definitely tell them not to do activities.
Yes, no physical activities, only for pain relief and range of movement, day-to-day function. You have to be really doing a lot of counseling for them.
So quickly running through this patient, you see, this is a 36-year-old lady. Can you see my slides?
No, I think you have to share data.
I think.
Mandeep, are we wrapping up or doing another case?
Okay.
No, it'll be quick, Vani, 1 or 2 slides, because plan is to hand over in 2 minutes on the top.
Okay. Can you see this?
Is that okay, Vani? Or do you think...
Is that okay to go to this quickly or not?
Sure, we have 2 minutes.
Yeah, okay.
By the
Can you
clock.
see my screen?
Yes.
Yes.
Yeah, okay.
Yeah, we can see, sir. I think can quickly share the pre-op and what you did in trauma.
That is the pre-op. 36-year-old lady had her elbow replacement done 7 years ago. She did well till then. This is a Bakshi elbow, which is in India. It's a metallic one. So you have a lot of metallosis. So very wide canal, thin bone shell, ulna is strict. And you can see all the problems I had anticipated. I measured it to get the right implant in. So I used a long flange elbow replacement. So that's the technique. And you remove, this has a unique hinge. You have to unscrew it. So you should know how these processes work. So you unscrew that and you dislodge the screw inside and you take it out. And that's the amount of metallosis she had. So all the cement, everything has been taken out. We broached it, a long stem. That's the elbow in. That's the alignment of the ulna. And you confirm there's no impingement, range of motion, VY-plasty of the triceps. And that's the range of motion she gets. So they do get good outcomes. And I think David had published extensively on this. And they do get good results, but complications rates are very high. So unless you're experienced in the elbow, getting into that is a dangerous territory. Thank you.
Thank you.
Thank you, Dr. Adla. That was great. And thank you, every panel member. And we officially hand over to Dr. Murthy.
Everyone, thank you for joining us tonight. We're going to talk about some irreparable rotator cuff tear cases. I have my awesome panelists, Anup, Ayapan, Rajiv, Terrence, and Bhupesh. We'll try to get through a couple cases tonight. This is Anup's first case. Anup, you on? Drive carefully. Don't get in a car accident. This is a 51-year-old male, acute on chronic pain, prior cuff 10 years ago, started having some new pain, has a low SSV. You can see his motion there is okay. Weakness, super infra, doesn't smoke. He's a truck driver. You can see his x-rays there. And so, Bhupesh, what do you think? What do you think about this cuff right now?
I can see the cuff to the level of the glenoid here, but the sagittal, the Y view, things look good. I always would like to see more of the scapula in the coronal plane, because here it looks like a massive retracted cuff, but here you see decent amount of muscle on the sagittals. So if we can see a little more of muscle bulk in the coronals, that will give us a idea of how things
This is
are.
all you get. This is all we can afford in the US. Only 3 slides.
So the good thing here is the subscap looks fantastic. So I
What would
think
be your approach here? Give me your algorithm in this patient. How old is he, Anoop?
he's 50 plus. What is his age?
Yeah.
Truck driver?
50 plus. Yeah, he's just over 50.
He's had a cuff before, 10 years ago.
He's got a cuff repair done 10 years ago?
Correct.
Correct.
Okay. So now I will go with two options. One is to do a revision repair because his muscle masses look good. The other is to do can you go back to the MRI? So his infra doesn't look great, but his infra is definitely going to be repairable looking at the scapula Y view. So I'm going to go with two options, go for a revision repair or an SCR, because if at all anything, I can get the infraspinatus back into place. And if I cannot do a good job with the supra, I will do a tensor fasciae SCR for him, or a SCRR maybe.
So what's your experience in India with augmentation, either biceps or a graft or a off-the-shelf graft? What is your experience?
We do a lot of biceps SCRs in these cases where we cannot get great supra in, but for a 52-year-old robust person who's a truck driver, I think the biceps alone wouldn't help him.
What do you think, Ram?
So sorry, is me?
Yes, just you.
Yeah. See, the biceps is gone already. The biceps is there.
Let's see. It might be there.
Might be there. Okay, biceps is there. You do a biceps SCR, and it looks like, as Bhupesh said, maybe repairable. If the cuff is repairable, if I can augment also with the biceps SCR, then I think these days I would love to do a patch augmentation. We have just started to do the cases in India. I have personally used a few cases each of synthetic pitch patch brace and bio brace, which is collagen with a synthetic patch. And third, also recently I started using cuff mend Arthrex human dermal allograft. So I'm just trying. I've done all the three cases now.
Ram likes to spend a lot of money.
A lot of money for the patient. But I think considering is the revision cuff repair, I think we have to do the best. If the cuff is repairable, I would go with the patch augmentation. My preferable will be either a combination like a bio brace or a human dermal allograft.
Terrence, how about you?
I think my thoughts resonate with whatever Bhupesh sir and Ram sir just said. But just adding on to it, I know Bhupesh sir is a big fan of doing SCRs for these SCRs.
Do
But
SCRs work anymore? Do they ever work anymore?
I think SCR, we have got good results shown by both Ashish Babulkar and Bhupesh Karthik. I have seen the cases presented.
Only Indian accomplished procedure then. Only Indians can do SCR. Is that what you're saying?
Apart from Japanese.
And the Japanese, okay.
The thing is, the term SCR is too big for us to put it in a single set, because the IT band SCR doesn't work well. But the tensor fasciae with the robust tendon sandwiched in between.
So how thick?
Get a good 8-phase graft. It works well.
So how big an SCR? You're doing like a really thick SCR.
Yeah.
Like Mahara, 8 millimeters.
8 millimeter SCRs. Yes.
Okay. But so we did 2 millimeters in the US, so 3 millimeters. So obviously,
I think that is the key, Anand. When we started to use SCR, the SCR original results was with the fascia lata with a thick SCR, but when it's translated to practice elsewhere, it was shifted to 3 millimeter. I think that may be the key issue. But when we do that with the 8 millimeter fascia lata with autogenous graft, the result seems to be good.
Anoop, hand up. What's up?
So a couple things. There's video with this, so you can play it for these scope pictures and some of the other ones later. So you can play the video. SCR, I'm just curious whether Indian colleagues...
Is that in your armamentarium anymore, Anoop? SCR?
You know, in the last 4 years, I've done 2. And I would tell you that the indications for us, I think in the US right now, have become significantly narrowed. And so I'm interested to know, what are the indications for SCR in India? that probably we're not seeing, because that procedure is, I'm not going to see, has been largely abandoned, but I think we are performing fewer and fewer. And I think even in the literature, it's been shown that the SER is kind of fallen out of favor to a large extent. So what is it that you guys are doing, and which patients are you doing this in? Because if you're using the biceps tendon, that's great. I would like to learn.
It sounds like first they're doing SCR differently than we're doing SCR. So they're using a thick autograft. We're using a dermal 3 millimeter graft. So it's semantics a little bit. So what's your best patient, Bhupesh, for an SCR? Just supra deficiency, infra is okay?
Yeah.
Okay.
The primary deal is you have to have a fantastic subscap or a repairable subscap. Because if your shoulder is going to shift anteriorly, your SER is not going to work. Of course, if you have a repairable infraspinatus, and if you can kind of tie your SER graft to your infra, then it is a great thing.
So if you did an excellent repair like Anup here, would you do anything else?
No, I think this is fantastic. I think I will just be very happy to go home after this kind of a picture.
The thing looks way over potential to me.
Being a revision repair, would you like
maybe
to
a patch,
augment it?
Maybe a patch there.
Maybe a patch, okay.
Patch.
But we are talking about patch for the last 2 years. But 2 years ago, I would have been very happy with this. Now that we have a patch, and then your mind always wants to do something else. But 2 years ago, when we didn't have access to patch, I would go home happily after this.
Happy with that, yes.
Does anyone do single row anymore? Single row repair, or always do you try to get a double row?
Double row.
Double row.
Very rarely when you have a small tear and then you just, or sometimes very big tears where you have to medialize a little bit. So very rarely.
Anup, take us through your technique and why you did this here.
Yeah, so this guy, he had a rotator cuff repair done before. I kind of gave it away with that Einstein saying of doing the same thing over and over again, expecting a different result. His motion was somewhat preserved. He was primarily weak. I showed those images, just specific ones for a reason, like, very little fatty infiltration. Subscap was intact. You guys nailed it. It was perfect. I was able to get pretty good excursion of the cuff. On these, the biceps was still intact, so I did a biceps tenodesis. It was really frayed and thin, and so that was one of the reasons why I did not use the biceps to help augment this. This was one of my first cuff mend cases, an acellular dermal allograft, and it worked really well. If you looked at my repair, I was not able to get everything posteriorly, so I still had some footprint still exposed, and that was the reason why I augmented this. Plus, this is a big, healthy, strong guy. I wanted to give him every opportunity I could, and I saw him at his 1 year mark, and his SANE score was about 90%, which I forgot to put on here. We also just published this earlier this year. It's not the most sophisticated study, but we did 18 acellular dermal allografts in my patients and revisions and massive rotator cuff tears. We followed them out for 1 year because this was not an industry-sponsored one and MRIs are not indicated. We used an ultrasound, a butterfly ultrasound through an iPhone with one of our primary care physicians. So he actually did not know what I did. I just said, I need to know if, our rotator cuff repair was intact or not. And we found out that at a minimum of a 12-month follow-up, 15 out of 18 were intact. We did have 2 that converted and so forth. And, I'm a big fan of this Rohi score. It's not perfect. We're not getting bone mineral density on every single person with rotator cuff tears, but I do think that this table, not this particular one, but the other one in this study shows the really big difference that once you get between, I think it's 6 and 7, that score, the healing rate goes down dramatically. And so, and it doesn't take a lot to get to 7 points. I mean, you have grade 3 fatty infiltration and you have a 3 centimeter rotator cuff tear and you're over 70. I mean, you're there. So I would highly encourage you to use this if you guys haven't seen it.
You all use the Rohi score ROM, Terrence, Bhupesh?
Yeah.
Or some assimilation of it where you're guiding your patients to their healing potential?
Yeah, the Rohi score is very useful for the pre-op discussion with the patient.
Yeah, exactly. I mean, it gives you a sense and gives them a sense of some expectation.
Anand, can I ask some technical question to Anup?
Sure.
I have done 3 cases of cuff mend now. I've done one yesterday. And I want to ask you, how did you secure the lateral row? Is an additional 2 knotless anchors distal to your footprint repair? And second, medially, how did you tie? Did you tie to the cuff using something like a fiber stitch or something available, or to the preloaded sutures of the cuff repair? How did you
Great
secure?
questions. Yeah, great questions. And my fixation has evolved medially. Laterally, I've just done it by the technique with the 2 lateral push lock anchors. They're self-punching. They're very straightforward. The biggest technical thing is just to keep your sutures separated because you're putting them in through that passport. So just make sure the anterior one, otherwise it's very easy to flip. So just make sure you know your color coding and you're visualizing either from the anterolateral or from the anterior portal so you can keep them straight. Paul Sethi has described inserting this posteriorly, and so that can change things. So you have a longer A to P coverage as opposed to medial to lateral, which can change some things. Medially, I was using the FiberTac tissue staples. They didn't work that well, so they were recalled. Then the second thing are the fiber stitches. Their initial fiber stitches were a little bit thick. They were a little bit big. And now we've transitioned to the knee fiber stitches, which are much smaller, shorter needle, and so forth. One of the pearls that I've now used is that once I've repaired my rotator cuff, I actually take a spinal needle. I'll either go through Nevisor's portal or anterolaterally so that I know exactly where the glenohumeral joint is, and I know where exactly I can push my needle and do that. So the fiber stitch takes a little getting used to because you don't need to really plunge. And when you're pulling back, you want to rotate your hand about 90 to 180 degrees so that implant can deploy and it doesn't pull out on the same trajectory that you have. The other option that you can do is, oh, go ahead.
Any tips on cutting the correct size? Because it comes in one fixed size. How do you decide what sort of shape you want the patch to be? And do you cut it?
All right,
Because
I'm pretty give him a quick answer.
Sorry. I typically use the 20 by 25. That's it.
Oh, perfect.
Okay.
Typically.
Thank you.
You guys can chat offline. All right. 60-year-old male fisherman. This is Terrence's case, I think. Presented with pain, shoulder instability, 2 years. Had a fall. This is his active motion, so pretty good. Pretty good. Let's do the other one here. Excellent. We'll go to some more. What are you seeing here, Terrence, on this on his exam? You're muted, buddy. Terrence,
you're on mute. Yeah.
Sorry.
There you go. Do it again.
Sorry. 2 years history of fall. He's a fisherman. His external rotation resistance test was positive. External lag was positive as well. Jobs was painful, but active movements was pretty good. Very muscular guy. I think deltoid is working very well.
So he's a healthy guy, fisherman. He's like our no tear. It looks like his teres is okay. He's weak. X-rays look like there's a little migration, but no arthritis. All right, let's look at his MRI. Let's go to the money here.
So you can see a retracted cuff supra-infra. The acromial distance is reduced. Not significantly, though.
What do you think, Anoop? What are you going to do here?
So does he have a lag, ER lag?
Yes, he has.
Terrence?
Yes.
Okay, and then, and so now when I'm looking at this coronal sagittal oblique, you can see a fair amount of fatty infiltration. Ooh, we are moving all over the place. Okay, and fatty atrophy.
We got to keep up.
Anand is so fast. All right. How's his subscap? I missed that on the axial.
Subscap's good.
This subscap is good.
Subscap's rock solid. Okay, so he's never had surgery before. He's got some proximal migration. We're assuming an acute injury. I would tell him that. Oh, it's 2 years. I'm sorry.
2 years.
Okay.
Chronic. It's chronic. He's got an external rotation lag.
Yeah. So for me, this case, I would counsel the patient and say, hey, there's a chance that we may be able to repair this. If we can repair this, we may augment it. But given the proximal humeral migration, on the x-ray, because that's against gravity, so that's more significant than proximal humeral migration compared to an MRI where you're lying down and you're supine. I may do a posterior inferior capsular release if that tendon, if I can bring it over. If not, I would have a conversation with him about a lower trap tendon transfer. Another option would be a tuberoplasty, but again, we've got to be really, really sure that his pain may be coming from articulation, but just given that lag and the ER weakness, I'm leaning towards a lower trap tendon transfer.
Bhupesh?
Yeah, lower trap all the way, because on the physical examination, that man looked robust. He had great trapezius when on the view from the back. So lower trap all the way. He wants to go back fishing, so lower trap.
Any indication anymore for latissimus transfer in your practice?
No.
No.
Terrence?
No. I mean, I think lower trap is easier.
It's definitely easier. And
We have moved and we've got very good results with lower trap for these kind of things. So we have almost shifted to lower trap for most of these, unless it's like a anterior superior cuff. Otherwise, it's lower trap.
What did you do here, Terrence? Take us through what you did.
So this was a diagnostic scopy. You can see that the biceps is completely gone. The first slide, I mean, I didn't record the subscap. You can see the previous slide, the subscap is pretty much okay. So here biceps was absent and you can see a degenerated cuff. It's all frayed. The edges are very frayed and it's bulky. So after doing all the releases, it was just coming up to the articular edge. So you can see that that's a posterior-superior cuff. It's coming almost till the articular edge, but the supra area was complete. Even the infra did not cover completely, and we knew that this guy had a exfoliation weakness and lag also. So we had counseled him previously for a augmentation like a lower trap. So at that time, this was a time about maybe 1.5 2 years back where we have started doing this lower trap, and we are doing using a Achilles allograft as the intercalary graft. Now we are pretty much shifted to using peroneus longus autografts. So most of our lower traps now we use peroneus longus autografts. So we take a pre-op yes.
Autograft, okay.
Autograft, yeah. So we are pretty much using peroneus longus for most of our ACLs. So we have just extrapolated that same concept to this also. Graft is pretty much good, and Achilles allograft is not very commonly available, and we need to pay extra. Patient adds on to the patient's bill, so we are more into peroneus longus using it as an intercalary graft now. So we did the same thing for this patient. We did a partial cuff repair, infraspinatus repair, we followed this up recently, and about almost 2 years follow-up, this patient is doing pretty well after doing a partial infra repair along with a lower trap tendon transfer.
Do you try to repair as much native cuff as possible, or do you go straight to the lower trap transfer?
No, definitely repair the native cuff as much as possible.
Bhupesh, how about you?
I first go with the tendon transfer, and then if I can pull in a little bit of supra, I will be more interested in pulling the supra, then trying to repair the infra, because the lower trap is going to take care of the infra's work. So,
how about you, Anup?
I am like Terrence. I try to repair as much as I can first, and then I will do my lower trap.
How do you do, Terrence? Should we show them?
Yes.
Any special techniques you want to tell us about your technique for lower trap?
It's pretty much the standard. So once we prepare the footprint, once we put the medial row anchors, after we do the repair, before you do a double row repair, you keep those the fiber wires from the medial row anchor up, so that once you get a tendon inside, you can use those from the medial row anchor also to additionally tie down the lower trap tendon. Use them additionally, and then put your lateral row anchors. So this is our incision from the back. Earlier we used to call our microsurgeons for harvest, but then we have picked it up now. It's pretty simple. And once we have harvested,
you don't need a microsurgeon to do this.
It was pretty new to us, and we initially had to call them. We called the plastic surgeons for help initially for the first 2 cases, and then we picked it up quite fast. So this was Achilles tendon allograft. So in our institute, we have a facility where we harvest these tendons, and we have a facility to store them. So this was our own Achilles allograft. So we do the whip stitching. We use a long curved artery to shift this tendon towards the anterior portal. So we have got it to the anterior-superior portal there. And the posterior half, then we use a pulver tap technique, and then get it through the lower trap and then stitch it back. And this
there's a nice technique. There's a lot of ways to do this, I think, for the lower trap, and it's different for primary versus revision, I think, too, the results you can get because of the scarring. But what position do you put the arm in for repair?
So
full an external rotation, full rotation. What do you do for positioning?
We keep it in external rotation. We keep it in almost full external rotation, and we have a custom-made brace which we give for them immediately after the patient is out of anesthesia. We give it on table so that it is maintained in external rotation. The problem comes is when you do a subscap repair, because once you've done a subscap repair, giving this external rotation, especially when you in one of our series we have our upper subscap tears in almost 50% of our patients, and once you do a repair, then giving an external rotation is a little tricky. So in such cases, I think you have to balance yourself and not give too much external rotation.
I mean, this result is great. I mean, you can see his external rotation. I wanted to put just a couple of mine on here too. I think it's really, for me, it's been when you have that indication of an external, of isolated external rotation lag with maintained elevation, these are some kind of typical results you can get. And like you said, it's not a difficult operation compared to latissimus. And I've done it in all ages, from younger to older. I don't know what age, if you have an age cutoff at all, but when you find that right indicated patient, it really works well. Mandeep, Vani, should we do one more? Should we finish? It's like 10 after 11. What do you think?
One more,
You're
maybe?
the boss.
Are there any questions here? Should we bring up?
I
just want to give a little. Oh, sorry, go ahead. Go ahead, Terrence.
How many of you do muscle sliding?
Yeah, that's a good question. Like Ashish Gupta has described, the muscle slide. Yeah, I've read about it. I talked to Ashish a couple months ago. I think it's another good option. You have to be a little careful releasing the nerve when you lift the muscle essentially out of the fossa, but he's got great results. So I'd like to also study it biomechanically, but I think that's another tool we add to the armamentarium. Obviously, it's auto. We don't have to add a graft. We don't have to do a second incision, right? Anoop, you had a question?
Yeah. Well, to answer his, I haven't done that yet. I've read about it. I'd love to learn more about that as well. You mentioned the technique of dropping the two anchors medially, and then you can fix them. One of the other benefits of that from a technique standpoint on this is that it helps prevent that graft from translating medially when you pulled it into the joint, which is a really another great pearl. I learned that from Danny Acevedo. He really taught us that. So just another little pearl for whoever's watching.
Vani, you said one more?
Yeah, hey, Anna, the one thing that just got brought up, it's a little bit before this class case, but just the idea of patch and maybe just talking about with the panel, the data on that. I mean, it's exciting because it sounds like in India they can use them. What's your experience? What's the data? What really exists on these? Because, I think that, Anand, as it's sort of biased a lot. There's a lot of industry partners in this as well. But maybe just getting the panel's thoughts on that and maybe addressing that.
On what, patches?
Yes, the use of patches.
So, Terrence, what's your, so let's go to, there's biologic patches like Regeniten, Tapestry, there's dermal grafts for structure, there's combo patches like the pitch patch, which is Europe. Do you have an indication for one or the other? Do you just use one for all? What do you do?
I have personally not used it, but my senior here, Dr. Sundarajan, we have just started using these patches, especially for cuff repairs, revision cuff repairs, I mean, and used a bit of Regeniten. But in India, there are a lot of concerns. One thing is biggest concern is the cost, because at that cost, it's around it's a huge amount for us. And if they are not insurance paying, then that is a issue. Second issue is the source from which this graphs come, because these patches come. Because if they are bovine, then people might have some religious issues to it for using. So they need to be counseled very well. But I think there are surgeons who are using it in routine cuff repairs, especially the degenerated. Like I recently saw a surgeon from Delhi, Dr. Deepak Chaudhary. So he's about 55 to 60 cases in massive cuff tests. Routinely, he's using post a good robust repair, like how Dr. Shah's repair we saw in the first case. He would use it in a for that like a routine way. I think there's no one single answer, because how do we provide biology has been the biggest question till now. So maybe it does help. We don't know.
It's hard to see biology improving with the dermal graft, right? Anoop, what's your indication for the various grafts?
So right now, I think it's a lot of the revision cases where I can actually obtain a repair. So these grafts are really an augment. I'm not using them as a bridge. If there is, I'm able to repair the tendon just to, the most medial aspect of the footprint, but 80% of the footprint is exposed. I'm probably not going to do an acellular dermal allograft for a graft purpose, but maybe you're going to consider a biologic tuberoplasty with a cable repair in that case. So I'm pretty specific. I have to get, for me personally, and again, that's just my opinion, I have to get more than 50% of that footprint covered in a tension-free manner in order for me to augment my cuff repair. And so whether that's a revision setting, if it's a primary setting and the cuff tissue maybe is not that great, maybe it might be a slightly poorer protoplasm in terms of a patient if they've got some comorbidities, the bone quality, and so forth. So that's really my indication. But I'll do it if I'm doing a subscap repair and so forth. It doesn't matter how many tendons are torn and so forth. It's just I got to get most of the footprint covered if I'm going to use it.
Excellent. Mandeep, Vani, I think that's a good endpoint. Anoop finishing us off with his knowledge.
Yeah, no, great.
Great.
Go ahead, Mandeep.
Yeah, so thank you, Anand, and thank you all the panelists. I want to first thank the ASI, the SESI, and the IASES organization for supporting this webinar. A big shout out to all the faculty members, including moderators and the panelists who took out their time on a Saturday morning in India and late night in US. And I think this just shows our commitment to education and developing a strong network with our Indian colleagues and spreading the word. So I want to thank everybody, including all the participants who are seeing the webinar. I really want to thank them as well. And we look forward to keep doing this and maintaining this for years to come.
Thanks, everybody.
Vani, any
Thank
final
you.
words?
You all.
See you the next time.
Thank you.
Thank you.
Thank you. Bye-bye.
Thank
Thank you.
Bye, everyone.
Thank you, everyone.
Hi, everyone. Thanks, everyone.
Thank
Thank you.
Thank you all.